van Westhuizen. My lord, ready?
Yes. Thank you. So actually, I think that we had one more question for you just before we broke for lunch, and it was under the topic, timing, nature and extent of lockdown restrictions, and it was just a question in relation to enforcement. How and by whom were measures such as, for example, restrictions on travel and other measures enforced in New Zealand?
Thank you. So the main enforcement was undertaken by our police. Actually, the main formal enforcement. The vast majority of the enforcement was self-enforcement, and I think it's the experience in most countries that if laws are reasonable, people will comply with them, and in fact, countries rely on the vast majority of people complying with those laws. And it was the same for our under our lockdown situations where there were very significant restrictions on movement, and the police would be stopping cars that were travelling. I didn't get stopped once, but people had to have a letter from their employer. It was a formal letter to say why they needed to be out and about. So the enforcement was a combination of self-enforcement and formal enforcement by the police. I dare say we also found out that there's, when you're in a situation like that, there's also people are watching what other people are doing quite carefully, and there was an opportunity to notify the authorities if you thought someone was not complying with the stay-at-home requirements. So there was some, I guess, for want of a better term, the technical term would be dobbing people in, and there was some of that. But I dare say again, most of it was just people complying, and that I think is, and maybe it's something we'll come back to, goes to the level of trust, which I think was whatever the response any country has. If there's a high degree of trust in the intent and the reasonableness of the response, then that's by far the most important factor in terms of compliance.
Well, I'll just ask another point just related to this, and I'll perhaps come on to invite you to speak about that issue of trust and how it relates to the level of compliance before I invite Dr. Tegel to answer similar questions. But in relation to that enforcement of measures by the police and their role, what did that mean in terms of compliance, these regulations mean in terms of compliance and community relations with the police and the communities?
So the approach taken by the police was similar to how they tend to police anyway, which is not with the sort of the strong arm of the law in the first instance. It's an education and support type approach, and so they weren't issuing fines or notices or prosecuting people so much as just giving people the opportunity to explain, and unless they were repeatedly offending, then it was more an educative approach. So this also became very important later on when we had outbreaks that affected communities that might have been quite marginalised, like drug users, and of course it was very important that we were able to contact trace, but people who may be selling drugs were reluctant to share what information they might have about possible contacts if they felt it was going to be used for enforcement purposes. But the police were very much of the view and took the approach that actually the primary concern was public health, and that they would not be using any information gathered for any sort of prosecution type purposes. So I don't think that enforcement role the police played, which was a minor part of their work, undermined trust at all in the police.
Thank you very much. And just in terms of public trust and the types of measures that were put in place and the importance of having public support, would you like to articulate or elaborate on that now?
Yes, and I think that public trust is absolutely fundamental to a successful response, where you're asking people to do quite extraordinary things, whether or not you're using legislative measures or not. And the three elements of what I would trustworthiness that I reflect on are honesty, reliability, and competence. And for us, the reliability was turning up at 1 o'clock every day and sharing all the information we had in an honest and open way, including about what we did and didn't know, and also knowing our stuff. So, and we reflected on this morning, the amount of preparation that would go into each of those, the stand-ups in particular. During the first lockdown of around 3 months in New Zealand, we were surveying the public every week because this was an extraordinary set of circumstances, and we wanted to understand how it was affecting people, including issues around anxiety or the development of mental health conditions, issues like domestic violence, as well as what people thought of the response. And there was consistently over 90% support for and trust in the response right through that period. And in fact, even as we got towards the end of 2021, when people started to get a bit grumpy, the public trust was still at a very high level in the response. And in my mind, that is probably the most important element of a successful response, whichever pathway a country chooses to take.
Thank you very much. Dr. Tegnell, we've already touched on Sweden's strategic response, and you've given an overview of what it looked like and the fact that it was led by the Public Health Authority. In that move from initial containment to a mitigation approach, it was also characterised by advice and voluntary measures rather than compulsory measures. And I think Sweden never had, well, it depends what you call a lockdown, but a strict lockdown in the sense that New Zealand had, but did adopt measures which you alluded to earlier in March 2022, such as banning large gatherings and limiting access to certain spaces. Could you describe the approach that Sweden took and why it was chosen, and in particular address the extent to which the law allowed or prohibited measures of the type that were taken in New Zealand?
Yeah, I think we talked about it a little bit already, but we also had different levels of response to a pandemic in our original plans, but I think the difference is that we went all the way to the top at once. So we never went back until the whole thing stopped. So there was never really any question about where we were. We always had a community transmission, and we needed to mitigate that as much as possible. So this was, I think, slightly different from the experience in New Zealand. There was no question about that. And there has been some discussion, I think, this internationally, about that there was legal. We didn't really have the legal possibilities to do certain things. I don't think that was really important, because we never really went that far that we really asked the government for. Because, I mean, of course, we could have had a new law in place if we thought it was necessary, and the government agreed with that. And I think we shouldn't overestimate what that did to sort of steer the response. I think we had a kind of two-level response. We tried to regulate businesses and restaurants and big events and so on as much as possible, but doing so in a very close communication with them, so that we could find something. And I think that was especially very clear when it came to restaurants, that we could find solutions that would both fulfill our goal of having people meeting each other less, keeping in the bubble. I mean, we didn't officially talk about the bubble in the same way, but it was interpreted in that way. So many people in Sweden also live within their bubble. And going to the restaurants in your bubble and not sort of meeting any other bubble, we didn't really see that as a problem. So, and if the restaurants could sort of cater to that, to see to it that you could stay in your bubble, we thought it was okay to keep open. And they gave us good ideas on how to do that. So I think, and that's sort of really very much the way we worked. We tried to find different areas where we did see problems, and then we sat down with them and talked to them about what can we do to alleviate the problem with the spread that you have in your place. I mean, workplaces, can people work from home? See to it that they can do that. If they need to go to work, see to it that you put up your structures in place so that people can stay in their bubble at work too. So it was it was not a staged response in that way. It was more a response based on the development of the epi situation. When we saw that we were heading into something that was worse, we tried to find, okay, what more can we possibly do? And then try to sort of put that in place.
And in terms of the trust that Sir Ashley spoke about, to what extent did that factor into either the decision to adopt the approach or the compliance levels?
You mean the trust?
The trust, yes.
Enormously, I would say. But also because this was not new to us. I mean, Sweden is to a great extent a trust society. Mm-hmm. It's very much built on trust. We don't really have much legal provisions in place in many places. And for example, even an oral agreement to buy or sell something is considered legally binding. Mm-hmm. It does not need to be put on papers. It does not need 5 lawyers to help you sign it. And that is very much, I mean, there are, of course, parts of society where it is, but for majority of society, this works. Mm-hmm. And the level of trust in institutions is very, very high when you measure it in different ways. Mm-hmm. And it has been for a long time, especially, and for the Public Health Agency, it increased during the pandemic. There was even measures about the level of trust in me personally, which I thought was a bit strange, but even that went up. And we also did this kind of thing, went out to ask people about, did you change your way of living? And so on, 80-90% constantly said yes, we did change the way. And I think you spoke very well about what you need to have trust. And I think it's all very much the same kind of things. It's also transparency and talking to people in a way to get them to understand why you're asking them to do things. We were very much working with trying to sort of say, this is what we're trying to achieve. Mm-hmm. We do realize that we all have different lives. We are trying to get you to meet fewer people. Think about what you can do. Here are some ideas. Work from home. Stay at home when you're sick and so on. Don't take the subway. Take the bicycle to work. And so everyone could sort of choose, this is going to work for me. I'm going to do my part. And I think the loyalty to that was amazing. We talk so very much about everybody being individuals these days in our societies, but when it sort of comes down to this, and I think the experience to New Zealand is the same, suddenly people feel that, okay, I can do this. Even if I think people in Sweden were very well aware of that, most of us, we can get COVID, it doesn't really matter. It's going to be like another flu. I'm not going to, but I can do that for my elderly or whatever. And I think that it feels sort of nice to be through something when people actually came together and really believed in that we can handle this.
Definitely. Well, thank you very much. The last question I have for you under this heading is just the approach that Sweden took, just generally in relation to measures. Was that taken at a national level, or did it vary by region?
Yeah, that's quite interesting, because normally our regions have very strong ideas on how they want to do things. So we thought, okay, now we're going to give them a kind of table with different things they can do, and they can choose themselves what they think is adequate to do right now. Different kind of. But very, very quickly they came back to us and told us, no, this is not going to work. This is going to be too complicated, and we're going to spend too much time trying to tell people why we choose that and not that and so on. We want to have a nationwide strategy that's going to work everywhere, even if we knew that, especially in the beginning, the spread of the virus was enormously different in different parts of Sweden. Stockholm took the brunt during the first wave. Malmö in the south had almost nothing. They had less spread than they had in Copenhagen. But even so, the people from the different regions came back and said, we prefer to do it jointly, because we think communication-wise it's the only way we can handle it.
That's interesting. Well, thank you. The next topic we have is a precautionary principle, and we'd like to get your views on the extent to which this was applied in both New Zealand and in Sweden in deciding whether or not to impose restrictions if I can invite Sir Ashley first, and not to put you on the spot, but just I'll ask you both your respective understanding of what the precautionary principle is, and then your views on whether you consider it was or wasn't applied in your respective countries. So if I can invite you first, Sir Ashley, please.
Yes, so in a sense, a precautionary principle means that you should take decisions and act and put measures in place even before you might have complete or indeed any evidence about what might or might not work. Now, of course, it's very seldom we would do it in the complete absence of evidence or information, and certainly early in the pandemic, in terms of published evidence, there was so little that I could personally read every new paper being published for the first 6 to 8 weeks. So we were relying on what was happening in other countries. We were, and because we had the advantage of our isolation, and our first case didn't come up until the end of February, we had the opportunity to look and see what was happening elsewhere, and so to move quickly in a more preemptive way, and you could say a precautionary way. I don't recall it ever being, our approach ever being couched as being precautionary. You mentioned earlier on the language our Prime Minister used was to go early and go hard. And I guess in terms of lockdowns, when one looks at the use of lockdowns, if you look at them all as a whole, and there have been some reviews done, they conclude actually they weren't effective. But actually experience shows there's a lockdown and a lockdown. There are two types of lockdowns, a lockdown at the right time and a lockdown at the wrong time. And if you waited until if you were going to use a lockdown, if you waited until your health system was overwhelmed to use it, then you got the worst of both worlds. Your health system was overwhelmed and you ended up having to use a longer lockdown to get back to the point you needed to be. So I guess our approach was precautionary in the sense of we may not have known exactly what was going to happen, but we took the opportunity to act early. And I'll leave Dr. Tegnell to talk about the other relevant P, which is the P of proportionality. And of course, this is very important. So every single decision that was taken like this that was going to restrict people's rights and freedoms did go through a legal test, because we have a Bill of Rights, and our Crown Law, our Solicitor General, would test every single one to make sure that there wasn't an unreasonable infringement on people's rights under the Bill of Rights.
Thank you very much. Dr. Tegnell, to what extent do you consider that it was applied in Sweden? Well, first of all, your understanding, does it accord with Sir Ashley's of what it is?
Partly, but it is a tricky subject, and you can interpret it different ways, and it's used differently in different circumstances and so on, so I think it's difficult. We never used that term ourselves, but we were sort of accused of not using it, and I don't completely agree with that. I mean, legally, in the Swedish context, the precautionary principle only exists in our environmental law. That's the only place where you can find it. And there it very clearly says you're not allowed to do something that you cannot prove is not harmful. So that's sort of really coming from the other side. So I think we relied much more on the issue of proportionality. You're not really allowed to do something that's going to hurt people if you can find another way to do it that's not as hurtful. And I think that's really what we worked with. But at the same time, I think in public health, we are very used to taking decisions on not complete scientific evidence, because it very rarely exists in public health in many areas, especially not when you have an evolving situation. So I don't think we ever had a problem with taking decisions that was not scientifically valid. I mean, we took a decision that we thought was based on the best available evidence at that time. For me, that's a much better term. And then maybe sometimes we had to change, because more evidence, more science turned up, and it turned up that the best available evidence at that knowledge at that stage was not the correct one. And I think we worked much more along the proportionality and best available evidence or knowledge at one stage. That was our leading things, and we never really internally discussed the precautionary principle. It was more the people from the outside who criticized us who said we were not precautionary enough. We definitely thought we were as precautionary as we possibly could be in the situation where we did exist, because I completely agree having a lockdown at the wrong time is counterproductive, and we were definitely past where you could use those measures very, very quickly. And I think a lot of people didn't completely understand that.
Thank you both for that. Well, then, I think, unless either of you have any further comments on the precautionary principle, we can move on to the next topic, which is data and modelling, and I think something particularly close to your heart, Dr. Tegnell. So I think if we could start with you first. Data was clearly a central part of Sweden's approach. Could you please give an overview of some of the types of data that were collected, what it showed, or what they showed, how they were used in decision-making in Sweden, and in particular for decisions about what was recommended or mandated in relation to public health?
I mean, we have an extensive amount of registries in Sweden. And we have personal identifiers, which means that we can, on individual level, collect different registries. This does not mean that it's easy to do that. I mean, technically it's very easy, but legally it's not. So there's very stringent systems around this, when you're allowed to do it and when you're not. So we shouldn't sort of really think that we could just run around doing it any way we wanted. We really went through all these different kind of things to really show that ethically and legally we did things that we were allowed to do. So data became very important for us, also because our registers are fairly fast. We do get report on new cases within 24 hours. We do get information about deaths within 2 days at the very most. So we had very, very quick data and very, very complete data.
And just, sorry to pause you there, just you spoke about the personal identifier number. Could you please explain a bit how that is, how that works, how that's traced,
each
and if that's
Swedish citizen or each person living in Sweden eventually would, at birth or whenever they enter the system, get a personal identifier, which is basically your birth date plus four digits in the end. And that is an identifier you use in any possible circumstance you can think about. If you go and rent books, or if you borrow books from the library, you would use it. If you go and buy food and you're a constant customer, that is also the way, and it's also used in all official registries. So the same number is used all over. So it means that we can at least in theory follow a citizen through our system very, very closely, and we have actually we do have a lot of collection of data where we can actually simulate this whole Swedish population and see where they work, where their schools, where their children go to school, and so on. So we can do a lot of modeling things on in a very real kind of, but still imaginary world. So they are really a fantastic instrument in many ways, and so we could use those data to follow very closely development, both on the number of cases and deaths, and also where those deaths took place, among age groups, geographically, if they were in elderly homes, what kind of profession they had, and so on. So we could constantly follow and see what were the risks right now and where do they exist, both geographically and in different parts of the population. On top of that, we got a lot of suddenly. We got the possibility to get data from many other providers also. So we got data from our mobile phone providers. We could follow how Swedes changed their mobility patterns because there was a lot of data on that. We could get data from the metros in Sweden to see how many people actually travel with metro every day. So there was plenty of other data that we could also use to sort of, I would say, mainly to follow how well people adhere to our recommendations. I mean, that was a big part of it. And I think that was also a big part of the trust and the level of people actually followed it, because we could give them feedback. Sort of telling a child how good you are, you're actually doing what I'm telling you. And this, I don't know if we haven't really studied it, of course, and it's not. I don't think it's possible to study, but I think it had a great part of that people actually kept on following our advice, that they could sort of see that we can see that you're actually following our advice, and you can also see that following our advice actually makes a difference. So, I mean, you can use data in many different ways. We also used it very much in a modeling sense to give our hospitals an idea about what can you expect during the next 3 or 4 weeks. Is there going to be more cases or less cases? And that was very, very important for them, because I mean, they had made big transitions in establishing more intensive care beds, and they needed to understand, are we going to push this further, or can we possibly slow down a bit and maybe do other things?
And was that based on infection rates, testing results?
That was based on what had happened in the past. It was also based on the prevalence in the population. We did big prevalence studies with a few months in between, where we went out and randomly tested people, so we had a good idea of the prevalence of the infection at any given time. And it was also based on what we knew about immunity in the population, and eventually also vaccination coverage and so on. And eventually our modelers got really good at this, and we could, once again, we did it afterwards. We also told people how good were we last time. So we developed this every other month. And then all the time we also went back, okay, last time we did this well. Actually, we were reasonably sure about it. And we always gave them 3 different possibilities. If everything goes really, really well, it's going to be like this. If what we really think is going to happen, this is it. And if it goes bad, it's going to be so somewhere in between these 3. But most likely it's going to follow only German. To really give people an idea of that this is not cut in stone. This is what we think is going to happen, and you need to treat it like that.
And you mentioned the various uses that the data was put to. Was it used to inform, I think you've mentioned this already, who was most at risk and who ought to be prioritised for vaccine? Were those included?
Eventually it was also used for that, yeah.
And to what extent was disaggregated data, for example, by gender, age, socioeconomic status, used to inform decisions?
I mean, I would say it was, because it, to a certain extent, told us where our communication works and where it doesn't. So that initiated quite a close collaboration with the regions and the communities in trying to reach our hard-to-reach populations, which does exist, spread all over Sweden. But most communities and regions are quite well aware of where there are sort of pockets of these kind of groups. And we had quite a lot of discussions with them, how to reach them better with communication, and how to reach them better with the vaccine offers once they came. So that were definitely very, very important.
And I think you've already touched on this in the context of teachers, but did the collection of citizens' data relating to the risk of disease by occupation type allow targeted interventions on the basis of occupation type?
Yeah, it took us away from doing that, I would say. So we went back and said that, no, we need to focus on the elderly and also people who have a lot of contacts with different kind of support services. So people with disabilities and stuff like that ended up in that group, because we didn't really see that they got sick much more than anybody else, but the risk, since they meet so many people every day, was higher. So we could sort of steer the initial doses of vaccines very much to those groups, and to a fair bit not steering them to health personnel and others that maybe felt themselves being at more risk, but we could show from our data, no, they are not really at more risk. And we had some quite heavy discussions with the regions around this, because the regions really wanted to have their people vaccinated. Not so much because they believed us when we said they're not going to get sick and die very often, but they still wanted to have their people at work. And I think that's still an ethical question that we're struggling with. But the ethical platform from the Swedish Parliament is very clear about that it's anything from a health service should be directed to the people that most need first. So other kind of things need to be second to that.
And you mentioned, I think, collecting data on deaths. Did Sweden collect data in respect of the mortality of vulnerable groups, such as those with profound intellectual and multiple disabilities, before, during, and after the pandemic?
Yeah, we collected deaths according to a lot of different groups. I'm not sure we collected exactly for this, but I'm pretty sure we did for people with disabilities. I mean, in Sweden, the registries give us possibilities to see that through that there are registers in people who get social support. Through those registers we could see that. And as far as I remember, we didn't really have an access in those groups, but we could follow mortality in lots of different groups.
And how was the number of deaths from COVID-19 measured in Sweden? For example, within 28 days of a positive COVID-19 test, or by some other measure?
No, we used the method of saying anybody who died and within 30 days had a positive COVID test is considered a COVID death until proven otherwise. So some were taken away because there had been a traffic accident and so on, but the majority. But what some researchers and regions did afterwards was to try to find out how relevant is this. And they went back into the hospital records and could see, okay, maybe about 50% of the deaths that we are recording according to this system is actually due to COVID. Another 50% is people dying with COVID. But that the official numbers we gave were the ones who had a positive COVID test and died within 30 days.
Thank you. So actually, in the case of New Zealand, what types of data were relied on there when deciding whether or not to impose or ease restrictions, and how was that used to guide decisions? And I'm assuming you don't have a similar identity. Well, I shouldn't assume, but I...
Well, of course, a very different situation for us. Just to put this in context, if we got one positive test when we were in alert level 1, the chief executive of the relevant district health board would ring me personally because, that would set off a series of events as soon as the Prime Minister found out about it. So, to your question, no, we don't have a single national identifier, but we do have a national health index number that is unique to each individual. So that allows us to link health information across testing, treatment, and across different providers. So that was a huge asset for us. And likewise, we do have what's called our integrated data initiative, which allows administrative data from different parts of government to be linked in a very closely controlled environment. So for us, the key data that we used were our testing numbers every day, because we would present these to the public to say, look, this is how many tests were being done, because we were encouraging everybody with any symptoms to go and have a test. Our test results and then our whole genome sequencing of the test results were pivotal to any decisions. We had a very inclusive definition of deaths, COVID-related deaths, as Sweden and many other countries did, so the 30-day or so, perhaps 28-day cut-off point, regardless, and we ended up with some deaths included that we knew were due to an accident, in one case a non-accidental injury-related death, but we still categorised it as such. But just to put this in context, we had just over 50 COVID deaths in the first 2 years of the pandemic, so it was a very different situation. We would use other data sources like travel data from Google to find out what was happening, and because we didn't have the actual numbers of positive tests and hospital admissions and deaths, we were using modelling a lot to work out what might happen under different scenarios, as well as feedback from our providers on the ground about hospital capacity and primary care capacity. And finally, as things progressed, as the pandemic went on, wastewater testing became a really useful tool for us, again, because it became so sensitive, and we could we had this around most of the country, and it would tell us, except where we knew there were isolation or quarantine facilities draining into a particular part of the wastewater system, and we knew we were going to get positive tests. If we found any positive results elsewhere, then we could ramp up community testing of people just to see if there was a case there, or to find that case and then act accordingly.
Thank you very much. And similarly, was data used in New Zealand to inform who was most at risk and who ought to be prioritised for vaccination?
Yes, absolutely. Although, of course, it wasn't necessarily the data based on our experience. It was our data based on what was happening in other countries and what we knew even from the small number of infections that we were having and the deaths we had those who were at higher risk. And as Dr. Tegnell has said, it was quite clear that age was a very, very significant risk factor. Unvaccinated or vaccinated, it was probably the most, being older was the most significant risk factor. And that was followed by, in our case, because we didn't have our first community outbreak until we had wide vaccination, having a chronic condition, especially in younger people, it put people at a much higher risk. Even though the number of deaths were very low in under 60s, the risk of death if you had a chronic condition was 70-fold. Wow. So and because our Māori and Pacifica groups had higher prevalence of chronic conditions, that we knew put them at higher risk as well. So this was very informative in terms of the measures that we would put in place, particularly the very strict measures around aged residential care and other care settings, and also informed our prioritisation for vaccination.
And to what extent was disaggregated data, and again, for example, by gender, age, socioeconomic status, used to inform decisions in New Zealand?
So we've got a sort of a deeply embedded approach to disaggregating data, especially by age, gender and ethnicity, to report on healthcare metrics. So that's just something we continue to follow, of course, through COVID, and became particularly important when we were doing our vaccination rollout, because we had some groups that had lower vaccination rates initially, and so we needed to be both collecting and reporting the data so that we could then try different approaches to increase vaccination rates amongst groups that had lower rates, be they age groups or ethnic groups.
Thank you. And again, like for Sweden, the collection of citizens' data relating to the risk of disease by occupation type allow targeted interventions on the basis of occupation type?
Only to the extent that our highest risk occupation were people working at the border, and particularly those in managed isolation and quarantine facilities. So these were people who were monitored daily for symptoms, had to undergo daily nasal swabbing and PCR testing, and who were then also the top of our list for vaccination because they were our highest risk occupational group.
And like Sweden, did New Zealand collect data in respect of the mortality of vulnerable groups, such as those with profound intellectual and multiple disabilities before, during and after the pandemic?
Certainly vulnerable groups. I don't think we disaggregated it by type of disability, but we certainly were able to report on whether someone had a disability and therefore the risk of mortality or of hospitalisation or mortality. But again, this was not really an issue for us until 2 years into the pandemic, when we had our first community outbreak, which was not until early 2022 with the arrival of Omicron.
Thank you. I think Dr. Tegnell's already mentioned it and you've touched on it. Just could you please give an overview of and examples of the key types of modelling that was undertaken and relied on in New Zealand, and whether and to what extent that was used to inform decisions about imposing or easing restrictions?
So I'm not sure I can provide different typologies of the modelling, but we certainly had a very significant effort stood up to look at what the impact of when we did get a case, especially, and then once we were having to make decisions about what alert level to use or when to move down to look at different scenarios using modelling based on the number of cases and where people lived and what we knew about movement that was happening. Mm-hmm. So modelling was extremely important to us because our numbers of positive cases were low, even in those small, sort of breakthrough community outbreaks in February, and particularly in August 2020 and February 2021. By the time we got to August 2021 and we had a Delta outbreak, that was more extensive. Mm-hmm. So we had more cases to put into the modelling mix, but then that helped inform decisions about which regions should remain in lockdown or not. And it was poor folk in Auckland that ended up being in lockdown for quite a period of time because of that modelling, what the modelling suggested.
Thank you. And in New Zealand, was modelling used at all to influence decisions on whether or not to keep schools open or to close them?
So, not specifically around schools. And the schools is keeping schools open or closing them was part of our alert level framework, and that was probably one of the most difficult areas, really, because there were different views around the extent to which children were at high risk if they went to school. Probably not, really. And one of the biggest inputs was not so much the impact on the students themselves or even the teachers, but the fact, of course, that they may be spreading the infection amongst themselves, and many of them being either very mildly symptomatic or asymptomatic, and then be infecting others back in their households. And our more vulnerable households, particularly Māori and Pacifica households, tend to have intergenerational households and bigger family sizes. So that was quite an important factor in decision making. So all these different pieces of information were weighed up at the same time, and modelling was one important input.
Thank you very much. Before we move on to just advice to decision makers, is there anything either of you would like to add in relation to the data used or how it was used to inform decisions made in your countries?
Just wastewater was also used in Sweden and in the EU. But since we were in a different situation, I mean, it was there all the time. Mm-hmm. We mainly wanted to use it for seeing that this was the start of a new wave. And I would say that it did not provide any, it was not quicker than the results we got from testing and so on. So for that purpose, it was not useful. And now afterwards, we have done extensive reviews of that. And I think what the experts have landed in, yes, it's useful to see if a new variant is coming, but not so much for measuring prevalence or where the epi curve is going or something like that. But since you tend to catch so many different kind of viruses at the same time, it might be useful to find that you have an introduction of new variants, and that seems to be where the knowledge stands right now. And it was also tested, I think, in some places to test for wastewater from airplanes to sort of try to make some kind of judgment, but never really came out very much out of that.
Thank you. If we could then move on to advice to decision makers, and really what we'd like to discuss is the role and membership of advisory groups that were providing advice to the governments, the scope of advice provided to decision makers, the extent to which other harms, for example, social, economic and health, were considered, including potential harms to vulnerable groups and risk of post-viral sequelae. So perhaps if we could start just with New Zealand, what types of advisory groups were available to provide advice directly to the government in New Zealand, and what what did they comprise? I mean, we've obviously touched on in the context of pandemic planning who was feeding in and contributing. What types of groups were they? Business interest,
Yes, so I think there were broadly two types of groups. First of all, the technical advisory groups that actually we would convene from the Ministry of Health, and they would be providing advice around, it could be specific areas like infection prevention and control, the advisory groups around what to do in aged residential care settings. There was a group that provided that sort of more general advice about options and in terms of response, non-pharmaceutical measures. So there was a range of technical advisory groups, and once we got into the vaccination program, there was another series of advisory groups. So these were people with technical expertise that we convened. Then the second sort of groups were more stakeholder consultation groups, so private sector groups, groups that were maybe groups of community leaders in our from our immigrant communities, our Māori leaders, as I mentioned earlier on, iwi leaders, Pacifica groups, young youth ambassadors, and so on. So the role of many of those groups was to provide a channel for communication out and for information to come in to inform the response. So they were really quite critical. As the pandemic continued and our response continued, the government also directly, ministers appointed sort of groups to review the aspects of the response, whether it was testing or strategic options for the response. So there were 3 or 4 review groups that were set up. One was around managed isolation and quarantine as well. So we ended up with over 1,000 recommendations from these reviews that were ongoing as the pandemic progressed too.
Thank you. And then if I could perhaps ask Dr. Tegnell, what sort of groups were feeding into decision-making in Sweden?
I think maybe run a bit differently, but very similar. I mean, we had a number of different groups in the public health agencies working with school questions, elderly care questions, personal protective equipment, that were mainly from within the agency, but many of them also had sort of contact points outside. So they had a network of hospital hygiene people and network of school people and so on. So many technical areas like that were covered, but mainly by groups that were run by and initiated by the Public Health Agency. Since it works slightly differently, we are then sort of collecting that and taking it on to the government. On the governmental level, the head this grouping was talking about before, who regularly called the directors from the relevant agencies to come to them and give them information. We also had a very important group in meeting with the communicable disease officer in the different regions, and that twice weekly. And then we also had a more general expert group that was called together, I think monthly, or, depending a bit on the situation, with experts from communicable disease control from the hospitals and from virologists and so on, sort of gave us more widely a way we could sort of bounce off also new ideas on how to do things. Apart from that, as I said before, we met with many different kind of groups, union leaders, religious leaders, restaurant leaders, and so many groups like that we also had regular consultations with. So.
And it's probably less relevant for Sweden, but was part of the information that they were feeding in about the impacts that they were experiencing in different scenarios and different groups, and to what extent was that taken into account in decision making? Oh, sorry. Yes. Sorry, Ashley.
Sorry.
It was just the groups that you spoke about there, and was some of the information that they were feeding in, for example, vulnerable groups or minority groups, was that information also about the impacts that they were experiencing? Yes,
absolutely, about the impact. And you also asked as part of your question, and just to confirm that there were the considerations the informed decision-making went well beyond health considerations. So this is where the cross-government groups, particularly the Chief Executive's Board and the COVID-19 team in the Department of Prime Minister and Cabinet, had a role of canvassing all the relevant information from across government, from ministries who would be, whether it was Education Ministry or Business and Innovation Ministry or whatever the sector. Transport, of course, was a really important part. So all that information would flow through into decision-making by ministers. The information from stakeholder and community groups was also really important in terms of helping to weigh up the decisions, and very often there was a tension between, especially as the pandemic evolved and the response evolved, there was a tension between vulnerable groups who might have felt things were being relaxed too quickly, and, for example, other groups and businesses who might be chomping at the bit for restrictions to be eased so that things could return more to normal and businesses could operate more normally. So the technical input was important, the modelling input was important, but so was the input from the different stakeholder groups, because a lot of this was, because it was our politicians making decisions, was balancing the different constituencies and their interests.
And to what extent was it appreciated or recognised before the pandemic or before restriction measures were imposed, what the potential harms would be, societal health, business harms would be? To what extent were those known or anticipated at the start?
Well, I think they were anticipated but not known. I mean, you can't shut down an economy or your borders for possibly like Scotland, New Zealand has a high reliance on tourism. And so, shutting down travel to the country was going to have a huge impact, as it did, of course, on the economy. So these were anticipated, but, of course, we were venturing into the unknown. And I think whether countries implemented a lockdown or not, there were many known unknowns and unknown unknowns. So we anticipated negative sequelae from measures like closing schools and so on, but of course we didn't know just the extent to what those would be, or indeed we didn't. There were some that we didn't anticipate, but that eventuated.
Thank you. And Dr. Tegnell, again in Sweden, what was known or anticipated in relation to potential harms for the measures that you did or didn't ultimately take?
No, I mean, I concur. I think many of them were anticipated, but quantity was unknown. We knew that a number of things was going to happen when you closed school because, I mean, it's quite obvious, many of them. But to what extent is very difficult to understand completely. And also what would be the extent of on the economy and stuff like that. I mean, many people try to figure that out, but it was very, very difficult to understand. And we also put in compensatory mechanisms by supplying many firms and so on with extra money to help them survive. Maybe even overdoing it, because we have seen, at least in Sweden, that companies goes bankrupt after the pandemic who had probably gone bankrupt during the same period of time, but they've sort of survived due to this extra money that was supplied by the government. So, I mean, we could definitely discuss this is going to happen, but how bad is it going to be was something we needed to follow and to understand.
We've touched on, vulnerable groups in a few contexts. To what extent was it appreciated that there may be disproportionate impacts on particular groups because of intersecting inequalities, etc.? Was that something that was recognised going into the pandemic, the potential for that?
Well, I think all our experience in public health is that any kind of crisis would always hit our vulnerable groups more than anybody else. So I think, once again, it was definitely anticipated, but to what extent and how? Because maybe some of them suffered more from our restrictions than they suffered from the disease, and the other way around.
And Dr. Tegnell, you've touched on some of the mitigation measures that were put in place. Can I ask, Sir Ashley, what mitigation measures were put in place, or some examples of the types of mitigations that were put in place by the Swedish government? the New Zealand government.
The New Zealand government, yes. Well, I think like Sweden and many other countries, significant support for businesses, financial support, wage subsidy schemes, and so on, which, some remarkable work done by parts of government to not only stand up the systems, but to release those funds very rapidly to ensure that businesses could remain viable. So there was economic support, of course, social support as well and I think this is what Dr. Tegnell may have been referring to as, one of the things we know is not good for health is loneliness, and people being isolated from the networks and relationships that sustain them and assist their physical and mental well-being, I think was something that was anticipated. So, and I should say, and this touches on a point that was made by Dr. Tegnell earlier on, the most remarkable thing was the sense of solidarity. And it's one thing to ask people to go home and stay at home and comply with a stay-at-home order, but it's another thing for people then to take on looking after each other. And this was the remarkable thing that happened. Neighbours checking in, not physically, but checking in with elderly neighbours to make sure that they were okay, to buy their groceries if they're going out to the supermarket. Church and other community groups mobilised extraordinarily, and this was, I think, one of the most remarkable aspects of the response. Yes, nothing else really to say on that.
And we've mentioned it before, but in the context, I think, of pandemic planning, but was post-viral sequelae ever considered in risk assessments or strategic planning during the pandemic, including plans to reopen schools?
Well, the information about post-viral sequelae, we might have, from a principles-based approach, anticipated there would be post-viral sequelae, but we simply didn't have any evidence, certainly for the first part of the pandemic. It did start to emerge quite early on, I think, though, from countries that did have early outbreaks, so perhaps Dr. Tegnell can comment on that.
Yeah, I mean, as an infectious disease physician, I know that post-infectious sequelae are not completely uncommon. It differs with different diseases, but it's definitely, when you have so many cases of a disease, it's not surprising that you see it coming up. Maybe we didn't, but it was very difficult to understand if it would, how much it would, and what it would look like. And I think we still have a problem trying to understand what this group is really about, because it's obviously a very heterogeneous group with many different reasons behind that they are now suffering afterwards, because suffering they definitely do, there's no question about that. And we are sometimes asked if this was calculated in as a possible risk and it would sort of steer decisions, and I would say no, because it was not difficult, it was not possible to calculate in any meaningful way, and we never really were there in our calculations. We did what we could to get the spread of the virus down as much as possible. And there was no really stopping that, except to see that any of the measures would harm more than do good. It was never calculated in how much it would sort of cost if we didn't do it, or so. To doing that kind of health economics was just not possible, built on the data, and it would not really lead us anywhere useful at that stage. So we never really did those kind of calculations. We mainly looked at, okay, if we do this and this is going to happen, this is positive, we're going to get a slightly slower spread. On the backside, it's going to get people more lonely and stuff like that. But to try to calculate in how much the cases would cost would have been impossible. And I think it's definitely a discussion we can have, but I'm not sure how it can ever be done better, I must say. These are things that's it's going to happen when we have these big new outbreaks of some things. And we, especially during the first wave, we saw a number of rather strange manifestations of this disease that I think in those days really worried us, because if this is going to be true for the whole period, I mean, these not only post-COVID, but many other things would also occur. Unfortunately, the variants of the virus that came afterwards was much less likely to cause these kind of things, which probably also was less likely to cause post-COVID. But so the fear sort of was a bit less after a while. But there is always things with a new disease that you don't understand at first.
Thank you. Now, just finally, in relation to the weighing up of the balancing of health risk versus others, how are the harms practically weighed by each of your governments? Is that something you were involved in or saw it in action? And do you know how that was practically done?
Judgment, and taken incredibly seriously. It's unusual in New Zealand for any officials to be in a cabinet meeting, but I attended the first part of cabinet meetings that were taking the big decisions, especially around starting or easing lockdowns, around vaccination program, around any mandates, and it was an insight, of course. I think we all know this, but decision making is taken incredibly seriously, especially when there's so much at stake. But there was never full, absolutely comprehensive information, and so ultimately it was a matter of judgment, weighing up all these different factors that I've described: the data, the information, what was happening on the ground, the views of different stakeholder groups, and weighing up the pros and cons. But that's what cabinets do day in, day out. It's just there's more at stake, and everything's at a much greater pace when there's a pandemic happening.
Thank you. And we've spoken about the other stakeholders, and just in terms of implementers, we spoke about them in relation to the pandemic planning. To what extent were implementers involved in feeding in and to decision making at the stage of deciding what restrictions to impose or lift?
Very much, I would say. The Swedish system is very much about getting wide consultations in society. So any kind of decision or any kind of similar document would always go out to a wide variety of stakeholders, implementers, or whatever you call them. So this also happened during the pandemic. It went a lot quicker and made people quite nervous that they needed to review a paper within a day when they usually have a month or two to do things. But the system kept being in place, and I think people really took it very seriously. As you said, I think taking these kinds of decisions were never done lightly. I mean, it was always many unknowns in it, and you need to weigh pros and cons, but you needed to take decisions, and I think that's what we all over the place really took decisions, because probably the worst decision is not to take one. So you need to decide. And,
Thank you. Before we move on, unless there's anything else on decision making, I had one more question for you, Dr. Tegnell, and it's going back to the modelling. In Sweden, the difference between modelled scenarios and the scenarios forecast from regional data differed because of the decision not to simulate the dynamic spread. Could you please explain what that means?
It means that instead of using a classical modelling setup where you try to sort of recreate the society and the different people and populations in it, and see what happens when we introduce this and this, and see how that's going to go on in your sort of fake society with all the assumptions you make for that, which is sort of the classical way of modeling when you want to do it sort of really well in the academic world. We saw that that's not going to work because there are too many unknowns of the different kind of variables that we put into that. So instead we went back and did more, I would say to some extent, what they do in meteorology. We looked at what has happened during the last 3 or 4 weeks. We add to that what we know about the present situation with immunity in the population, vaccination coverage, prevalence of the disease from other studies. And based on that and sort of a our previous experiences, what's going to happen, we project, but for a very short period, only 2 or 3 weeks at the most. And doing that and learning sort of AI-like, but in the heads of people, we managed to get reasonably good at that, and we found that was the most efficient way of doing it.
Thank you. My lord, we're about to move on to the next theme, and we're 10 minutes away from our break. I can press on, and we can break at 1:45, I think is our break. Or we can break now, which, and come back early, yes. I'm in your lordship's hands.
Probably best to keep the themes together, I would guess, to be perfectly frank. So we'll break now and come back at, let's work this out, 10 minutes before the hour. Very good. Thank you. Now, again, when you're ready, Ms. van der Westhuizen.
Thank you, my Lord. So moving on to theme 3 now, which are methods of infection prevention and control beyond what we've already discussed. The first topic we have is borders and quarantine, and I think we'll start again with Sir Ashley. Perhaps we could begin with New Zealand's border strategy. Your written response describes how the country moved from early restrictions on travellers from China in February 2020 to a full border closure by March, and eventually to managed isolation facilities. Could you please talk us through how those decisions were taken and the challenges there were in implementing them, please?
Yes, so of course all those decisions, as I've mentioned earlier on, were taken by Cabinet based on public health advice. In the first couple of months of the pandemic, we were still using the influenza pandemic plan, which did have this phase of keep it out. So we were doing our very best to keep it out or detect at the border, and then asking people who might have infections that had arrived in the country to isolate, to try and reduce or prevent the possibility of community transmission. So yes, we moved quite rapidly from some restrictions at the border to then, within a week of the announcement or the characterisation by WHO of a pandemic on the 11th of March, a week later we actually shut our border to anyone other than New Zealand citizens returning to the country, and then very soon after the whole population went into the lockdown on the 25th of March. At that time, anyone who was travelling from overseas had to self-isolate. But within a couple of weeks, we had put in place a system of mandatory managed isolation and quarantine for people who were coming from overseas. If they were tested at the border and found to have an infection, then they went into one facility, and then others had to isolate for 14 days or go into quarantine for 14 days in a range of hotels that were repurposed, and we gradually built up the capacity to do that. So the border measures were, and then those were in place for well over a year, 18 months, and they were a really important part of us being able to maintain an elimination strategy.
Thank you. And I think the Commission report boasts the fact that the social, economic and personal costs of border restrictions and quarantine requirements were very high. Are you able to articulate what those costs are? I suspect we've covered some of them already, but specifically in relation to border control.
Well, the principal one was there was only limited capacity within those managed isolation and quarantine facilities, and so there were many more people who wanted to come back to the country, New Zealanders, to either see family or to move back than were able to get places. And so there was a real challenge around determining and implementing the right system to do this on a fair basis. And for many people it felt that it became a bit of a lottery. And at the same time we were still trying to have international sporting events. So sometimes we'd have international sporting teams coming, and they would have access to quarantine or quarantine places that New Zealanders couldn't then access. So this, I think, was a major source of discontent, and for some people they felt really were very upset about this fact that they couldn't get back to see family members, or indeed, for example, at times that might be a very unwell or a dying relative, parent or a close relative. And so whilst there were compassionate considerations and exemptions, it was that restriction on the number of people, even if they were New Zealand citizens, being able to come into the country that really caused, I think, the most concern and created that negative social impact.
Thank you. Dr. Tegnell, Sweden didn't have similar border restrictions as far as I understand, and I think the government had suggested the possibility of border testing for arrivals, and the PHA advised against that. Is that correct? And if so, why?
Yeah, if you mean that the government now is looking into what kind of legal things we need to have in place, and also what kind of practical things we need to have in place to be able to do it in the future, yes. They've asked the agency to look into that. We have looked into it in the past too, and it is complicated, partly because of our regional system, because it would then be the regions who would have to sort of handle that, because they are the only ones that could handle it. And they, of course, are not too happy about getting that kind of responsibility, and the responsibility would be very uneven, because some regions have very heavy. It's going to have an incredibly heavy load, and others are not going to have anything at all. So it is a tricky question to put it up, and we have not really been able to, in the past, get any kind of in place that seems reasonable. So we'll see what can be done, because it's, it's to a certain extent very much a question of volumes. And the volumes are quite different between Sweden and New Zealand. And also I think we, at least the way we interpret the law, we can never really prohibit somebody from coming back to their country. We cannot even delay it. So even if we don't have the resources to sort of put them anywhere, we cannot really stop that. And we all know that testing and so on at borders are never going to really provide any good protection. I mean, if you want to do it for real, you also need to put people in quarantine for a certain amount of time. And when you have big volumes doing that, it's a logistic problem to agree, and financial problem, because who is then going to pay these people? The loss of income and all of these kind of things. I mean, many people during the pandemic ended up having to spend a lot of money being quarantined in places where they could not, where they had to pay for it. So it's not easy.
No. And there were some border measures taken by Sweden. There was, or were there some border measures taken?
Yeah, there were border measures to a certain extent, together with all the other EU countries. We followed sort of when there was joint measures towards, for example, South Africa for a while, and for the UK and so for a while. So then that did not really do that much, because we don't really have direct, most of those times we did not really have direct flights or direct travel to those countries, so they would still have to go through another EU country before they came to Sweden. So it did not really put a lot of pressure on us. But it's tricky, because I mean, in Europe most people come maybe to Frankfurt, and then they go on another flight, and how are you going to be able to know where they came from? And I mean, it's the logistics around it is, in a place like EU with open borders and a lot of connections, and people traveling by train, bus, and car, and bicycle, and I'm not sure that we ever can do anything about it. And I can still remember when EU put down saying that we should have restrictions against any country, there was always a long list of exemptions. And towards the end, those list of exemptions extended over 3, 4, 5 pages with all the different things that needed to come across our borders, because there were essential goods or essential people and stuff like that. So it's complicated on many different levels. And can be done in a place like New Zealand, but for many other countries in our global world, it is not possible to have some kind of control at borders. Health control has not either really proven very helpful when we look back at Ebola in West Africa or SARS or so on. I mean, when the evaluation was done afterwards, among those, it did not really prove that it made much of a difference. The only thing that I think at some stage proved reasonably efficient was to have exit control, like they had in West Africa for a while, and that probably made a difference.
Oh, thank you. I think if there's anything else. I think we'll then move on to testing, contact tracing, and self-isolation. And just briefly, we'll run through a few of these topics, but the availability of tests, the mandatory testing for certain groups, scientific knowledge of asymptomatic transmission, procedures for collating information and coordinating contact tracing, including the use of technology, the adequacy of testing and tracing capacity and prioritization of testing, self-isolation requirements and measures to encourage compliance. In New Zealand, Surashi, when did tests first become available, and to whom were they available and how were they accessed?
Yes, so testing became available initially in February, and the challenge was then scaling up the availability of testing through our laboratory network in the country. And this happened relatively quickly, and what was put in place was really community-based access to testing for anyone who had symptoms, and it was free. And as I mentioned earlier on, it was all PCR-based testing because we needed the most accurate and most sensitive form of testing. So this was a big part of and a mainstay of the approach that was taken in New Zealand, was that very ready and cost-free access to testing, whether it was through general practices or every district health board was required to stand up community-based assessment centres where testing was freely available. And so access to testing was not really an issue. And mandatory testing was introduced for a number of groups, in particular our border workers, with regular testing as well for healthcare staff.
And so was it just the border workers? Was that the only category?
So yes, anyone working in and around the border, which could mean airline staff, especially those who are flying internationally, those who are flying in. We ended up with just one airline bringing passengers into New Zealand through Dubai, and so that made that, sort of managing the border a lot easier for arrivals. But yes, all our border workers working in border settings, customs officers, and especially those working in managed isolation and quarantine facilities, depending on which group they were in, the frequency for some of them it was daily, some weekly, but daily symptom checks.
Thank you. And what advice was being given by your department for, or the relevant public health authorities for prioritisation of testing, and what was that advice?
Well, the advice was less around the prioritisation of testing because it was freely available. It was more around which groups should be required to have regular testing, and then an order was put in place to require those groups, particularly border workers, to have regular testing. Thank
you. And if I could ask Dr. Tegnell when tests first became available in Sweden.
Yeah, testing became available very early on, as soon as we got the sequence from China and from WHO. Our lab, who is kind of a central lab for Sweden, developed the test and spread them to all the regional labs. So testing, the problem was not really that, the problem was the volumes. That was later on needed. So. But the test was in place very early on.
And did Sweden have mandatory testing for any particular categories of worker or otherwise?
No mandatory testing. It was really up to each workplace to decide if there was any necessity to who was supposed to be tested and why and so on. And in the Swedish system, you cannot really do things like that mandatory. What the employer then has to do is to tell the person who does not follow the advice from the employer to give them other work. We had the same discussion within the area of vaccines, for example, and so on, that this is the way to handle it, but mandatory is not possible to do.
And in terms of advice being given by the PHA regarding prioritisation of testing, if there were limits on the numbers you had, what was that advice?
I mean, for quite some time we did not have the capacity to do community-wide testing because the volumes were not really in place until, I think we're talking May or something like that, when we finally got everything together. And the priority was really to test for medical reasons. That is to sort of steer the treatment of the patient. So this was the first priority. And then the testing of hospital and elderly home staff.
And when was it first understood in Sweden, or that the virus could be transmitted by those who were asymptomatic? And how did this knowledge impact on public health advice?
Yeah, I mean, that was discussed quite a lot, and I think we still don't really know to what extent. And I think, once again, there is a difference between if you try for an elimination strategy when you want to catch everything, and when you want to work with a strategy that just tries to diminish. And it was quite clear to us that the majority of the transmission took place with symptoms, no question about that. So the part that happened asymptomatically was likely fairly small and not really relevant in the Swedish strategy. But many, I mean, many different researchers have tried to calculate what amount it would be. What we did, which I think is quite interesting, we did this prevalence test, which a few thousand Swedes being tested every other month, different groups the whole time. And we did not find even one among those that tested positive that did not have symptoms. So that's made me sort of really wonder or be quite clear about, yes, it does exist for sure, but it's not that common. And I still remember the very first description of asymptomatic testing of a Chinese woman who managed to infect people at some German meeting, and afterwards it became clear that the people writing the article had not talked to the Chinese woman. She was actually with the symptoms and had taken paracetamol to alleviate those, and there was no question about that. So, yeah, asymptomatic spread does exist, I think, but it's not really very common, and the way we judged it, that in the Swedish context it was, except for really special groups, it was not really relevant to change anything around that. And
what about in New Zealand? So actually, when was the awareness that it might be there might be asymptomatic transmission, and how did that knowledge affect public health advice?
Well,
if at all.
The assumption there was asymptomatic transmission was something that came up very early on. The idea or the suggestion of asymptomatic transmission, plus at that point in time with the original virus, quite long latent period. I think it was on average was about 4 or 5 days, and of course as the variants appeared, that sort of period from infection to symptoms just got shorter and shorter, and so by the time we got to Omicron it was so short, and it was actually that relatively long period that enabled effective contact tracing, because you could by the time someone got tested, you had time to identify and isolate their or quarantine their contacts, and so this is really what enabled a vigorous testing and contact tracing approach, which is obviously was a mainstay, core public health intervention. And what it of course required was not just the testing, but the ability to follow up large numbers of contacts very quickly. And have confidence then that they were not only going to isolate, but were supported to isolate, that they could take 14 days off work, that their employer would support them to do that there might be financial support and social support if they required that to do that. So all these different things had to be put in place.
And just in terms of the requirements in the event that somebody tested positive, what were those requirements, and what were measures were put in place to enable them? You've touched on that you needed a suite of measures, either support from your employer, but what support was available in New Zealand from the government?
So there was, because there were small numbers of these cases, especially when we had the community outbreaks. In fact, during the August 2020 outbreak, this is after we had done our first lockdown, we are now COVID-free. Essentially, we had a small outbreak in August 2020, and a requirement was put in place for anyone who tested positive to actually go into a managed isolation or quarantine facility. So that, again, required an order under the COVID-19 Act. And this was very helpful in terms of and so it would be the person plus their household contacts, even if they were asymptomatic, because that was where there was the highest risk of transmission. So it wasn't until really the August 2021 outbreak in Auckland that the requirement came in for people to isolate at home, and that was more challenging because there was variable compliance by that point in time. But just to reiterate, there was financial support provided to people to be able to isolate, and also there were specific initiatives to ensure they had the social support they might need to, whether that was deliveries of groceries, if they had dependents that might need support to do homeschooling, then these were the sort of cross-government supports that were available.
And there was a requirement to register attendees at certain venues, for example, cafes and restaurants. How did, could you explain the evolution of contact tracing and that response in that regard? For example, the role of digital contact tracing and the app, Bluetooth, telehealth, etc.
Sure. So initially, this requirement for hospitality venues to register people who came in was a manual one. But then quite early on, and I was just refreshing my memory, in May 2020 we launched an app, a COVID tracer app, where people could download the app rather than writing it manually, and then just scan a QR code when they visited a venue. And within by August that year, actually, all businesses were required to display a unique QR code. And so it made it easy for people, if they were attending any business, whether it was a hospitality venue or a retail outlet or some other business, to just scan that code. And then those data were collected, and then we could identify people who might have been at a business if there was a case there, or if someone who was suspected to be a case had gone there. Subsequently, there was Bluetooth enablement of that as well, so if people's phones got within a few metres of another phone, there would be an encrypted signal that would pass on the information there, and then those people would be notified, not to be told you were close to this person, but just if someone tested positive as a case, the people who had been within the period of a week, say, beforehand, whose Bluetooth signal had picked up the Bluetooth signal of that phone, could then be notified anonymously and told, you've been near someone, can you watch for symptoms and be tested at the first sign of symptoms. So these things just help make it easier for people to get out and about and do their normal lives, and also for hospitality businesses to effectively operate as normal. This is under Alert Level 1 when there are very few restrictions in place.
Thank you. Just in relation to Sweden, what was the overall success of your test, trace and isolate, and how much more difficult was it when transmission rates were high?
It was fairly successful in the beginning with the first imported cases, because then the volumes were small and we could do it in time, because this is what it all comes down to. When volumes becomes high, and we looked into it afterwards because our government asked us to review what was the usefulness of testing and tracing, and we quickly found out that the volumes were so big that you didn't really reach the contacts until it was too late, especially in the later stages when the incubation period was so short. So when I talked to a few, because what happened is that most of the regions established contact tracing centers where they got a lot of people coming in, retired nurses and stuff like that. But I think what they sort of felt as their main function was really to inform people, give people information, both the cases and the contacts, so that they should be more understand what were the recommendations, what could I do, what couldn't I do, and stuff like that. So it was useful in that manner, but the classical contact tracing that we do for STIs, sexual transmitted, does not work when you have these enormous volumes and the big turnover that you have in this kind of situation. And we have had, because we did a review of contact tracing and testing together with our Nordic neighbors, and Denmark was sort of the outlier here. They used testing. They tested, I think each Dane was tested like 8 or 10 times or something like that. So they did enormous. And they, I mean, their main argument for doing this huge amount of testing is to be able to get people to understand that I'm actually infected and infectious. So it did not entail any other obligations or forcings or anything like that. It was mainly to get people to understand that now I need to be careful. They felt it was to a certain extent misused because young people tended to test themselves and then go to a party. And we all know that testing is only valid for the exact second you do the test. I mean, you might be positive 2 hours later. So it is a kind of, I think we agree by now, it's a kind of a risky way of using it. And I definitely think we need to think more about testing and contact tracing for future pandemics, because this was the first time ever that we could do testing at this kind of level. In previous pandemics, the strategy has been testing and tracing very, very much in the beginning. Once you have a community transmission, there's no need for it, no usefulness. You test the people to give them the right medical treatment, but for nothing else. Now we did a lot of testing, enormous amounts of testing, all through the pandemic, and I think we need to carefully look at that. And of course, it's one situation in New Zealand when you sort of have been able to get rid of the virus and want to stay that way, but a completely different situation when you have an established community spread. And what is the usefulness of testing in that situation? I think we need to carefully look into that, and I don't think it has really been done yet, but hopefully. And then, of course, once again, every pandemic is different, so next time it might be less useful or more useful. We don't know. But it costed the world enormous amounts of money.
My lord, I think we might have reached our time limit for today and just gone over it. So we have a few more topics, but we'll resume those tomorrow.
Good. But I don't imagine you're...
Oh, I'm so sorry, my lord. I'm an hour early.
I did think it was early, I must confess. But...
Oh, no, we have plenty of time. Yes, this was obscured.
Actually, you're not an hour early, because we started 10 minutes earlier, so you're 50 minutes early.
Okay. Well,
bear that in mind.
We'll move swiftly on there. Then to
but I mean, quite seriously though, if round about 4 o'clock, pick a point at the end of one of the topics that you've got. Don't stray into you've got vaccination, PPE, care homes and vulnerable groups. I don't imagine you get all those done, but don't stray into one if you're not going to finish it, even if that means a few minutes earlier.
Good.
I'm sure the witnesses would agree they don't want to be coming back to think about something that they've already started.
Great. Well, then we'll move on to vaccination strategy. So again, these are questions for both of you, so I'll probably take a question at a time and put it to each of you in turn. When was the vaccine available in New Zealand, first of all?
So we received our first vaccines on the 18th of February 2021, so probably a little after most other countries, and it was probably because we were a little further down the priority list, remembering at the time we had countries where healthcare workers were dying regularly, and in our country we had no cases. And the other part about that was just that, it was the sequence within which the first vaccines we got, I should say, were the Pfizer mRNA vaccines, and but we were ready to go to start within the next day or two to get vaccinating.
And in Sweden, when did it become available in Sweden?
We gave the first vaccination on the 26th of December 2020.
Wow.
This was a common EU start of the vaccination program because, as you probably know, the vaccines were procured by EU, and the Commission felt strongly that they wanted to make a manifestation on that. So we received only a few thousand doses, but the first vaccine was given on that date. But then the main program only started a couple of weeks later.
In terms of order of priority, what was the order of priority in New Zealand in relation to the vaccination?
So we had developed a very comprehensive prioritisation document, which had been approved by Cabinet, and this was intended to accommodate the fact that we were receiving the vaccine in batches in different at different times over the subsequent 8 or 9 months. We started with our highest risk people, who are our border workers. The ones, because we're an elimination approach, they're the ones most likely to be exposed to the virus. And then we moved into our healthcare workers and others who might be caring in the community, not necessarily healthcare workers, but caring for people who could have COVID. And then we started with prioritisation based on risk if people got the disease. So that very much into the an age-based approach from that point in time. So starting with our older people. Now, one of the contentious issues was that we knew Māori and Pacific people had higher risk because of their a range of factors, including a higher risk of chronic, higher prevalence of chronic conditions, and so there was a strong push for an ethnicity-based prioritisation as well. In fact, what the government decided to do was to work with the age-based approach, but it provided our Māori and Pacific health providers with access to a certain number of vaccines, about 40,000 vaccines, to be able to target through their channels their populations, and still starting with the older people. And actually for the first 2 months of the rollout, we had higher vaccination rates amongst our Māori and Pacific older people than we did our non-Māori, non-Pacific, which is a very unique example in New Zealand where you can have higher rates. And this was a testament to the effectiveness of those providers and being able to reach into those communities. And it was something that we then learned from and used later on as we rolled out into other age groups, where we had some groups in the population who had a distrust either of government or of the health system, and really needed to develop that relationship of trust with people like those providers to then be willing to come forward and be vaccinated.
Thank you. And what about in Sweden?
The Public Health Agency had been asked by the government to develop a priority vaccination plan already, I think, in August or September or something like that. So we went through that, very much focusing, as I said before, on risk, medical risk. And we also took it past our ethical board. There is the Swedish ethical board for medicals. So they also looked at it and approved of it. Basically, it's said to start with the elderly care homes, and then go on to elderly people with some kind of home care, and other groups also with home care. So they were definitely highest on the list. And then quite soon after that, also other medical risk groups with chronic conditions that considered, and then basically age structure. As I said, we had a big discussion around medical health personnel. We were not very keen on doing that because we didn't really see a high risk in that group in Sweden, which I think is interesting because, as you said, many other countries reported. I think that to a certain extent shows the effectiveness of hospital hygiene in the Swedish setting, which is really high, I would say, compared to many other countries. So, and also that most patients that came into healthcare were not all that infectious anymore because they came in quite late in the disease. But whatever. So, but in the end, we managed to get the regions to say, okay, these are the really essential people, small group, not everybody that works in the hospitals. You will get some vaccines to cover them in parallel to doing this basically age-based work.
Thank you. And in terms of encouraging people to be vaccinated, what steps were taken in Sweden to encourage uptake, if any?
At least in the beginning, we didn't really need to encourage people. That was not the problem this time, which is interesting. It was a big push, and not maybe also because the vaccines came fairly slowly. So there was waiting lines and so on. So people really didn't need to get pushed. They pushed themselves. So, but later on, it was more about that, and then to a certain extent, of course, that you needed to be vaccinated to be able to travel, push people. We should not forget that. I'm not sure how big that was, but it was definitely there to be able to get this kind of certificate that made it possible for you to travel was important. We also really try to reach our hard-to-reach communities in different ways, and the regions and communities worked a lot with that, sort of driving out to big sports events and trying to get into these kind of communities because we could clearly see in our data, yes, they got vaccinated, but they were vaccinated later on. They waited longer than many others. So if there was any push or try to create incentives, it was mainly towards those groups.
And in New Zealand, you've already mentioned the outreach to hard-to-reach groups, or certainly a group. What about encouraging people to get vaccinated? Was there an appetite, or were people willing to come forward to be vaccinated? Or?
Well, a similar experience to Sweden. Probably for the first 6 months, it was people. We had more people complaining that they couldn't get the vaccine, I sort of work on the basis about 70% of people were waiting at 1 minute past midnight when the booking system opened to book their vaccine and crashed the system. And then there's about another 10 to 15% of people you just have to put a bit more effort in or make it easy for them. And so a key part of the strategy was having a wide range of places available. So we opened up pharmacies for vaccination. We changed our regulations to be able to train a whole new workforce to vaccinate. We had mass vaccination centres. We even had a vaxathon day where we managed to vaccinate 130,000 people in a day. And so we had no trouble for that first probably 70 to 80, up to 85%, but it's that next 5, 6, 7, 8% that you really need to work hard and be absolutely prepared to spend money and have bespoke options and opportunities for those people. And some of those people and their families might require 4, 5 or 6 interactions and until they can build a relationship of trust. And there was also the use of, and there was some controversy around whether we were incentivising people to be vaccinated, because some of those providers, they were given, they were enabled to use grocery vouchers and other things to help just encourage people to come along, perhaps have a barbecue or something. And so there was a range of initiatives that were put in place to really encourage, and a huge advertising campaign, of course, as well.
And overall success strategies, I think, overall success of your strategies, was that across the board, or were there certain groups? You've already mentioned hard-to-reach groups, but were there certain groups that were it was less successful in relation to?
Well, there was still some variability at the end, but in New Zealand we managed to have over 90% of our population aged 12 and over received 1 dose, and over 80% received 2 doses by the end of November 2021, and then we undertook a booster program because when we were finding out about waning vaccine effectiveness, so we were into a booster program in our highest risk groups. So that's a very, very high coverage. There were some countries that got higher than that, but the most important thing was in our vulnerable groups, particularly our over 65s, we had 97, 98% coverage, and that was the most important group, and they really benefited from having that very high coverage.
And in terms of side effects, what were the reported levels of side effects to vaccines in New Zealand?
Well, this is one of the really important aspects of implementing such a wide vaccination program with a new vaccine, is to have absolutely rigorous reporting of any potential side effects and review of those reports by an expert group, particularly any that were considered to be severe side effects. And of course, the evidence started to emerge with the Pfizer vaccine, which is the one our program is based on, of myocarditis and cardiac symptoms, and in particular the risk in younger people. And so there was very rigorous follow-up and a consideration of any case that was reported, and there was a range of mechanisms put in place to make it easy for people to report side effects, and then there was expert consideration of those reports. And of course we were looking, because we were a bit later than other countries, we were avidly following the reporting that was coming in from countries that were also doing this real-time follow-up to make sure we were adapting our program. And so very early on we specifically added the myocarditis risk to the informed consent process and information that people received, and also what people should look out for, so that they would take immediate action if they felt they had any of the symptoms.
Thank you. And Dr. Tegnell, what were the reported levels of side effect in Sweden?
No, I mean, I completely agree. It was extremely important to have a good system in place, and I think we had. It was very much based on our experience from the swine flu and the pandemics and the narcolepsy. So after that, we really built a very strong system for this, with very quick and strong registers, both for vaccinations and also big possibilities to report any kind of side effects, both for an obligation for the health services to do it, but also possibility for individuals to report in if they felt side effects. So we had a strong system to catch up signals, and then when we saw a signal, I mean, we have the good registers in Sweden and in the Nordics, so we could actually sit down with our Nordic neighbors and pool those different registers that we had and look at any kind of signal we had. And that's, for example, when we found that Astra had a slight risk of blood clot events, which we didn't think was acceptable, so we stopped using that vaccine and so on. And we also communicated very clearly on this. The Medical Product Agency joined our press conferences at regular intervals and told everybody about how many reports do we have, what do they show, and all of these kinds of things. These vaccines had a fair amount of side effects, light ones, which I mean, I think it's even more impressive that we managed to reach such high levels of compliance, because fever episodes and pain and so on afterwards were very common compared to many other vaccines. So this was, but we followed very closely, and I think there was a high level of trust in that we did it so carefully.
And you mentioned there AstraZeneca. What vaccines were most used in Sweden?
No, the mRNA. In the beginning, we had more of a mixture, but eventually we went over more and more to the mRNA vaccines. This was, I mean, as you know, the procurement was done on EU basis, so we had signed contracts for a number of different vaccines.
I'd like to then move on to vaccine passes and workplace mandates, and this is obviously something that was prevalent in New Zealand. I understand that vaccine passes refer to government-issued passes whereby those vaccinated could attend events, and that the workplace mandates were for certain public servants, whereby those in certain occupations were required to be vaccinated. And then the third category was employer powers to mandate vaccination. What was the broad rationale behind these three methods or mechanisms, and the reception from society, employers, workers and unions?
Yes, so the broad rationale, again, recalling we were still an elimination approach here, was we were wanting to reduce the likelihood of any community outbreaks and or the extent of such outbreaks should they occur. And this was a very, very challenging, it was probably the most challenging subject on which to give advice and I think for politicians to make decisions. But mandates were widely used in a number of countries and for different groups. In particular, we were interested in, and we implemented mandates for our healthcare workforce, for teachers and for emergency workers and defence personnel. There was quite a strong push from the private sector for the government to require many other groups of to have mandatory vaccination. And the approach that was taken, as you mentioned, is the government provided an enablement for the private sector to implement mandates if they wanted to for particular roles. The vaccine passes were designed to allow businesses to reopen, and in particular in the service sector. This is once we had the community outbreak, and to do so in a way that was going to minimise the likelihood of further spread. This did create, this was not favoured, of course, by people who had decided not to be vaccinated. And they felt that this was unfair. So saying there was a very, very strong support for it from the people who had been vaccinated because they had felt that they had done their duty, got vaccinated, protected themselves and helped protect others. Remembering, as Dr. Tegnell said earlier on, most people knew that for them COVID might not be a particularly serious illness, but that they were being vaccinated to protect both themselves and others. This was also predicated on the knowledge we had that there was some protective effect of the vaccine in terms of infecting others. And in fact, for the early variants of the virus, this protective effect of the Pfizer vaccine had quite a reasonable benefit in this regard in terms of stopping onward transmission of the virus to others if a person was vaccinated. That reduced over time with subsequent variants. So that was something that we took into consideration. So yes, we implemented vaccine mandates. The mandates became, I would say, a lightning rod for dissent around the whole COVID response, really. And because, part of that, I think, was the overlay with the increasing misinformation that was being spread internationally about the vaccines. And so you had this overlay of the mandates with misinformation about vaccines, and therefore this became the sort of the main channel for ill feeling and dissent.
You've mentioned there about being vaccinated protected others. To what extent was that sort of philosophy applicable in Sweden? Were people volunteering to be vaccinated on that basis as well?
I think classically and also when we did the pandemic plans, there was really the hope that the vaccine would work also in stopping transmission. Unfortunately, this vaccine did not do that very well. I mean, there was an aspect to it, but it was not very strong compared to what we are used to from measles vaccines and so on. So we never really communicated that as a reason to get vaccinated, because since that protection level was too low, so to speak. So it did not really play in very much. The main role of the vaccine became, and I think that was apparent already from the studies in Israel to begin with, that they could see that a fair amount of people even get vaccinated, tested positive afterwards, not with much symptoms, but still tested positive. So the main reason, the main objection of the vaccine to start with was really to protect our health services as much as possible, because they were definitely very good at stopping people from getting severely ill and needed medical or intensive care.
Did Sweden have anything akin to what New Zealand had in relation to vaccine passes and mandates?
We did have a vaccine pass. There was also an EU-level vaccine pass that was developed in I think, all EU countries. Something was agreed on, which was mainly used for travel because a number of countries demanded that you had this vaccine paper when you entered. From the national level, we never recommended it to be used for any kind of events and so on, but still some organizers of events, when they started up late in the pandemic, still on their own accord asked for that to happen. And that was, of course, up to them. There is no sort of legal possibility to, legally they could do that. So that did happen, not very extensively, but it did happen now and then. So it was, as I said, mainly used as a travel tool. I would say that we have a long tradition of voluntary vaccinations in Sweden, and I think to go against that would have really created a lot of discussions and a lot of problems in the long run for us. So we were very negative to that. And as I said before, employers needed to do their own risk analysis if the personnel in certain situations needed to be vaccinated. If they didn't want to, they had to put them in another workplace. And this is how we could deal with that. And some employers, especially in health services and so on, where the personnel took care of very fragile people, they did ask their employees to get vaccinated. If they didn't want to be vaccinated, they had to perform other duties. So it was never really a big issue. And I think compared to many other European countries that I talked to afterwards, this was never really a dividing factor and did not really cause any controversy. People were quite happy about the way it happened, and no discussion afterwards or queries about, we have what most countries have in social media, the vaccine, anti-vaxxers, so to speak, but for some reason they never really take off in Sweden. We still have a childhood vaccination program that reaches 98% of all kids and so on. And this has not been influenced by this at all.
Thank you. Was there anything else? I think we can then move on to our next topic, which is PPE and the use of face masks and social distancing. And I think we'll be discussing the availability and use of PPE and separately face masks. If we can start again with New Zealand. So Ashley, against the backdrop, we've already had a discussion earlier about the backdrop of PPE stockpiles being inadequate. How is procurement and distribution managed in New Zealand, and were there any particular issues with this? For example, community-based services and care homes getting access to protective equipment.
So I mentioned earlier on about our district health boards perhaps having not stewarded their pandemic supplies to the extent that we might have expected. So very early on, we nationalised back into the Ministry of Health the system for procuring and distributing PPE, and that was also to include distribution to community-based providers as well as for use in the hospitals. And we kept that national system in place for the duration, really, of the elimination strategy. The big challenge then was sourcing and PPE and getting it delivered down to New Zealand when many shipping companies and airlines had stopped coming to New Zealand at that time. So that was another challenge, and we had to build up the supplies. In terms of the advice around use of face masks, early in the pandemic, that we were not advising use of face masks, and this is probably one area where it's we were perhaps a bit out of step with our otherwise quite precautionary approach when, on the face of it, first principles would have suggested face masks could be useful, but we were actually following the advice of our infection prevention and control experts at that point in time. It's also worth remembering that WHO itself wasn't advising necessarily widespread use of face masks for quite some months into the pandemic, and it wasn't until later in 2020 that we changed our advice around use of face masks generally for people. They were already available and being used in healthcare and aged residential care settings. So that was one area where the advice initially was not to really use face masks very widely, and again, and I mentioned earlier on this, probably a misplaced focus on the spread of the virus on surfaces and by physical contact rather than by aerosolization, rather than droplet spread. So once though face masks did become part of the response, then they were used widely, and in fact we subsequently introduced their mandatory use in a range of settings, including on domestic flights, many people in different workplaces, certainly hospital settings, healthcare settings, aged residential care settings, and so on. But by that time we had sufficient supplies for them to be widely available. They were also distributed out to our community-based providers to spread, to distribute to our higher risk populations, disabled people, older people, and those with chronic conditions living in the community.
And did requirements for, you've obviously mentioned it being mandated in particular circumstances and for particular individuals. Could you just elaborate on what those were, for whom and in what circumstances, and also at what alert levels they were required?
So what was the last part of the question?
It was for whom, in what circumstances, and at what alert levels?
Right.
Yeah.
I'd have to just refresh my memory about, because that's quite a little bit of a level of detail around all the settings and which alert levels. But the main requirement was for their use in alert levels 3 and 4, and aside from healthcare settings, education settings were another place that masks were mandatory and required. And also, once we had a community outbreak, actually any shop, retail setting, hospitality setting, people had to, well, it seems a bit odd, but wear a mask in, but then they could sit down and eat a meal, take their mask off to do that. I've talked about aircraft, public transport. So really anywhere where there were indoor public settings, then masks were required to be used. And
did requirements for mask wearing change at different levels? I think you'd mentioned there that was mainly at 3 and 4. So presumably at different levels there were different. It wasn't a blanket requirement. When you're in 1, you're effectively out of lockdown. So
that's right. Yes. In alert level 1, it was pretty much life as normal. We had music, big outdoor music events and so on happening. I think we were one of the few countries in the world that did. So, of course, by then we also knew that it was indoor settings that were the issue. That you don't need to walk around wearing a mask outside, really. But it was public places and places where people would have interaction with others.
And you mentioned there mask wearing in schools. Who was required to wear, and was that for teachers and for children? And if children, was there a cut-off an age below which you weren't required to wear them in school?
Yes, so in schools it was teachers and students from year 4 upwards, so that's children about age 9 or 10 were required to wear masks. Very tricky. Of course, and they didn't need to wear them when they were outside. It was just inside the classroom. That was combined with other measures, and of course what we knew by then was that adequate ventilation was a really important part of reducing risk, so whether that was opening windows or having air recirculators in classrooms, there was effort put in place a range of measures in addition to use of masks.
So were there any national ventilation or air quality standards introduced in public institutions such as hospitals or other health or social care settings? You've mentioned schools already.
Not standards per se, but there was CO2 monitoring was made available, and then there was a big effort to put in to provide or make available air conditioning or recirculators in schools, hospitals, and so on. It wasn't something that we'd really thought about before, but it's something that quite a lot of effort was put into.
And how was the requirement to wear masks enforced? Again, you mentioned the businesses. Was a condition of entry into, for example, restaurant venues, as you mentioned, you can take it off once you're in, but was it a requirement for entry? Was it enforced by the police? And what were the consequences of non-compliance with mask wearing?
Yes, so this was just, like most good laws, it was self-policing, really. So it was a condition of entry into many premises, public and private, and masks were made available for people in public places, going to a chemist or any healthcare facility, hospitals and so on. The intention was to make it easier for people. There were also exemptions available for people who had a good reason not to wear a mask, and that may be because of a disability or some other reason. But there were people who really didn't like the idea of being required to wear a mask, and so they felt that restricted their ability to go into certain places.
And I think you mentioned there, was there an exemption for those perhaps with disabilities? I think, was there a scheme that was coordinated by disability providers from late 2020?
Correct.
That issued a card that could be carried.
Correct, and it was challenging to administer that scheme, but there was a special request from the disability community that an exemption process could be put in place, and so we enabled them and funded them to administer and deliver that scheme.
And was there any specific type of mask that was recommended or required?
Well, it was the classic, very cheap surgical mask, but actually what was required of people was a face covering. Mm-hmm. So that could be a homemade mask, it could be a scarf, but it was recommended that people used what was made available for people with a classic surgical mask. Within healthcare settings, our healthcare workers were all provisioned with N95 masks, which were known to be and shown to be more effective. And
how effective was the use of face coverings or masks in reducing the spread? Or is it difficult to say?
It's hard to quantify. Yeah. I don't think it's possible to quantify that, but there were a lot of studies that we could point to that were done quite rapidly and were published that showed the reduction in risk of transmitting the virus if one or both people were wearing masks.
Thank you. We can perhaps turn to you, Dr. Tegnell. Again, against a similar backdrop of limited stockpiles, could you please explain how the procurement and distribution was managed in Sweden and whether there were any issues, particularly in the early days?
Yeah, as we said before, there was a problem because there was basically no stockpiles, and the whole world market was running after masks. So it was not easy, and the regions, some of them being fairly small, and their possibilities to get out on a world market and buy things were limited. So in the end, the government went in and asked the National Board of Health to set up a system to procure masks on a national level and then redistribute them to the regions. So that was the solution that was put in place to make it possible to have them available.
And in terms of the consequences of the lack of PPE in the early days, who was deprioritized or who went without, for example?
I think our main problem in the beginning was that the elderly homes and the caretaker, especially the personnel there, didn't have access to, and didn't really have knowledge either to handle them in a good way. So that was really something that was pointed out very clearly, that how big of a part they were in sort of the big problem we had in the elderly homes, I think is very difficult to judge, but definitely the availability was lacking. And I think in the hospitals, they in different way managed to keep supplies enough for their personnel in the hospital setting, so there was never any real problem. But especially in the beginning, the elderly homes had a real problem in getting enough masks into place.
And just in terms of the requirements for masks, I understand that it was never mandated in Sweden, unlike New Zealand, although briefly it was recommended in crowded public transport. Why was that recommendation made?
Because we then were into a new wave, and there was a lot of anxiety about that this was going to be maybe even bigger than the previous ones. We had quite a high level of vaccination coverage, but the vaccines did not really stop the transmission. So we really felt sort of more or less compelled to have something more in place. And this was one of the few options that we felt were left. And it was quite restricted, because it really said it's better to take the next train than to step onto one which is crowded with a mask on.
Yeah. And were any specific types of masks recommended in Sweden?
Yeah, I mean, for hospital personnel, I mean, we're talking about the level after the surgical masks, and that's where the masks were used. So, but this was according to sort of the standards put in place already before. So this was the normal hospital hygiene level to use. So there was no sort of surprise about that.
And did knowledge of or acceptance that COVID was airborne have an impact on mask wearing or the approach to mask wearing recommendations in Sweden?
Yeah, not really, I would say, because I mean we did not. First of all, we have already quite strong rules about the air flow and so on in any kind of public building. So those regulations were already in place, and to increase those did not really seem feasible or necessary. So that was never really a discussion. And I think our focus on trying to find places where there was a lot of transmission was more important than the discussion if it was airborne, droplet-borne, or however it was borne. I definitely agree that this idea in the beginning that all of these surfaces needed to be cleaned all the time, that was never really very important for anybody. But again, I think this division between droplet-borne and airborne is a shaky one. It's not very easy to divide diseases into the two different groups, because most diseases spread both ways. And that's why I think we had a focus on these are places where we have a problem. Not so much a discussion if this was airborne or not airborne, because obviously it was both, and it depended very much on the setting, which was most important.
And again, are you able to see how effective in Sweden it was in reducing the spread when it was recommended on public transport?
Sorry?
Are you able to say how effective the recommendation was to wear it on public transport?
Probably not very effective. The local region did a couple of small surveys to see how many people actually use masks, and it was very low percentage, 20-30% or so, who actually use face masks. And on top of that, the spread never became as acute as we thought. So that's the reason also why this was quite a short-lived recommendation, because actually what looked like the start of something new panned out, and we did not really have any big problem after that.
And in terms of national ventilation or air quality standards, were those introduced in Sweden, for example, again in health and social care settings or schools?
They were already there, so we did not really change them in any way. It's not completely easy to change those kind of things, because it means heavy investments and rebuildings and stuff like that. So, but in the regulations for buildings, for buildings for everybody in Sweden. There is already regulations on the number of air turnovers and stuff like that, so we lean back on those. I think in Sweden we have had quite a lot more concern about that historically, because we had quite a lot of problems with mildew and stuff like that in many buildings. So that's why we introduced this kind of regulations to avoid that, because, I mean, due to the climate we tend to build quite isolated houses. But that also means that you need to have a good possibility of ventilation in place to live with that. So I think we never really had that kind of concern, and I don't think our data even talks about that that we had a big problem in those kind of places. And I think that comes back that we have another kind of building tradition and ventilation tradition than in many other countries.
And there was some criticism in the Corona report about the rejection of face masks as an infection control measure. What are your views on that?
No, I'm in opposition to my colleague here. I don't think the science and the data is really there. I mean, Cochrane did a review which showed that it's shaky. I think it's incredibly difficult to measure it in doing it blanket-wise. I think you can definitely have ideas, and I think definitely in crowded spaces and so on, they would definitely make a difference if you use them the proper way. And I think you would use them the proper way in those kind of circumstances. But I think the problem that many European countries had, having these kind of blanket mandatory things, and I mean, if you look at these countries afterwards, it did not really help them. I mean, Spain, Austria and many other countries had huge spread in spite of those mandatory. And I mean, you can do a lot of sort of laboratory research in showing that, of course, it stops the virus if you use them the right way, no question about that. But when you try to go out and do population-wide things, I mean, Denmark tried to do one, they didn't manage to show that it did much of a difference. It was a very good study. They sent out face masks to limited amount of population, compare them to the rest, and there was no difference in the criticism of that was that it was during a time when the spread was not very high in Denmark, so it was difficult to show anything. Another interesting study, which you probably know about, is the Bangladeshi study, where some villages got face masks and some others. And it showed a small effect, but at the same time they also did a lot of other things. So I think it's often difficult to say that this was due to face mask and this was other things. So it's a tricky. I mean, it's also a signal which should not be underestimated. So the physical thing is one thing, and the other thing is the signal, and maybe that will make a difference in certain situations. I'm still doubtful, and I still think we need to find more precise ways of using it, because it's both costly and takes quite a lot of information to get it done in the right way.
My lord,
You've got the time right this time.
Pardon? I've got the time right.
This
It's yes, 3 minutes past 4. I am about to move on to the next one. I'm happy to start, or happy to, just conscious of time tomorrow, we're quite short on time, but we can perhaps trim.
Yeah, I'm sure they can. Very good. We'll stop there for the evening. I think we're starting at, let me be correct, 9:30 tomorrow morning. Very good. Thank you all.
All right.